Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of speaking with a dear friend and colleague, Dr. Giorgio Bogani, who is at the Istituto Nazionale dei Tumori di Milano in the Department of Surgery in Milan, Italy. We're going to be talking about a very comprehensive review on uterine leiomyosarcoma. Again, it is such a pleasure, Georgia, to have you on the podcast, and really thank you for the opportunity to speak with you on this collaboration and obviously a very pertinent and important topic to us in gynecologic oncology. So thank you again for accepting our invitation.
Thank you, Pedro. It is my honor for being here with you and help and resisting this podcast with the International Journal. Thank you so much for this invitation.
Yes, thank you. I wanted to just start by just discussing overall, what is the frequency of uterine leiomyosarcomas, and what information can you give us regarding clinical presentation and overall prognosis for these types of tumors?
Okay, let's start with frequency. And the uterine leiomyosarcoma represent a rare and highly aggressive entity, accounting for about 1 to 3% of all gynecological cancer and 3 to 7% of all uterine malignancy, with an annual global incidence ranging between 0.5 and 3.3 cases per 100,000 women. Uterine leiomyosarcoma represents the predominant subtype of uterine sarcoma, being about 70% of all sarcoma of the uterus. It mainly affects women aged between 35 and 75 years, with a peak between 40 and 60, basically perimenopausal, menopausal women. The etiopathogenesis is multifactorial. Most patients lack for clear risk factors, but there are some factors that are associated with an increased risk: older age, black ethnicity, prior pelvic irradiation, long-term tamoxifen use, and some type of genetic alteration. Symptoms are unclear, not specific, and in general, they overlap with benign uterine condition and fibroids. The most common symptoms include abnormal uterine bleeding, an enlarging pelvic mass, pelvic pain. And speaking about prognosis, we have to say that despite its rarity, uterine leiomyosarcoma significantly impact the gynecological practice due to its aggressive nature, resistance to current therapy, and poor prognosis. In fact, the overall 5-year survival is about 40%, and clinical stage is the main factors driving prognosis. 5-year survival is estimated to be about 50-75% for stage 1 disease and 10-15% for stage 4 disease.
Excellent. So thank you for that introductory overview, Giorgio. And we'll get right into some of the questions from our fellows in the journal. This first question comes from Masha Pervan at the University Hospital in Münster, Germany. And she's interested about the routes of diagnosis. She's asking, what routes or ideas do you think should be pursued to diagnose uterine leiomyosarcomas reliably preoperatively?
It is a very good question. I think that managing uterine leiomyosarcoma presents unique challenges, and in particular, achieving at early and accurate diagnosis is essential. Accurate preoperative diagnosis remains a relevant unmet need, in fact, and there are not available laboratory or imaging criteria that help us to distinguish uterine leiomyosarcoma from fibroids. No serum marker are diagnostic, although LDH, CA1 to 5 can be elevated, they lack from specificity and predictive value. And imaging may help. Transvaginal, transabdominal ultrasound has initial assessment, MRI for local characterization of the disease and for the evaluation of local extension, CT scan of the chest, of course, and the abdomen for staging. And PET-CT can be useful when unclear findings are detected or to assess the presence of distant metastases with a good sensitivity and a good specificity. However, as we said, no imaging or laboratory tests are available, and histological examination of the uterine specimens remains the only certain way to perform a correct diagnosis.
Yeah. As a follow-up question to that, Joanne Naveau from Memorial University of Newfoundland in St. John, Newfoundland, asking a question that I think, of course, obviously we've all come across. She's asking, in your review, you emphasize the challenges of distinguishing a leiomyosarcoma from a benign fibroid. You also mention emerging tools like radiomics and artificial intelligence. Which of these diagnostic approaches do you see as most promising in actually changing clinical practice in the future?
I think that radiomics, artificial intelligence, machine learning, as well as molecular approaches such as microRNA profiling can be promising, but they are investigational strategy at the moment. In particular, radiomics extract high-dimensional quantitative imaging features that correlate with tumor heterogeneity and aggressiveness. Moreover, AI-based algorithms are being developed to integrate imaging, histology, clinical data to enhance diagnostic accuracy and predict treatment response. However, all those technologies are still research only, and further validation is required before adopting into clinical practice.
Yeah. Along those same lines, staying on the imaging theme, Itzi Villagra from La Paz University in Spain, she's asking, ultrasonography, uterine leiomyosarcomas are characterized as large, single, solid lesions with irregular profiles, heterogeneous ecostructure, central necrosis, and moderate to rich vascularization. Many of these features can also be seen in fibroids. Should any of these ultrasound features in particularly raise suspicion for a possible leiomyosarcoma, warranting referral to a gynecologic oncologist?
Yes, you're right. On ultrasound, uterine leiomyosarcoma typically appears as a large, more than 8-10 centimeter solid lesion with irregular contours, oval shape, heterogeneous ecostructure described as Cook appearance or microwave appearance, according to our ultrasonographer expert. But the most important features are the central necrosis or irregular cystic areas in the center of uterine leiomyosarcoma and the moderate to rich vascularization on Doppler. While it is true that signs can also appear in benign fibroids, the combination of clinical features like the rapid growth of the mass and with ultrasound signs, including central necrosis, devascularization, should raise concerns to clinicians. In such case, a referral to a gynecologic oncology unit is warranted to avoid inappropriate surgery, morcellation, but also inappropriate surveillance.
Yeah. Now, this question also from a very important clinical scenario, and of course, I think many of us have encountered this type of situation. This comes from Tommy Meschini at Filippo del Ponte Hospital in the University of Insubria in Italy. And he's asking, how would you approach counseling a patient with a desire for fertility and a preoperative suspicion of uterine leiomyosarcoma versus a benign leiomyoma? Would you recommend performing a biopsy to decide between myomectomy or hysterectomy? Or given the risk of dissemination and the histopathologic challenges in establishing a diagnosis, would you instead proceed directly with definitive surgery?
I would like to thank Tommy for this question because it's very compelling, interesting, and fertility sparing is one of the main, my main preferred area of interest. I think that fertility sparing surgery, that's myomectomy, is not recommended given the tumor aggressiveness and the risk of dissemination. Because preoperative biopsy and also intraoperative frozen section have low reliability. And we have to consider that all those procedures that we perform to spare the uterus may cause peritoneal spread. And in case of high suspicious hysterectomy without morcellation remains the standard treatment. Women with desire, with fertility desire, must receive the individualized counseling that should emphasize two important points. One is the high risk of local but also distant recurrence. And second, the lack of data about the proven fertility sparing safety and efficacy in this setting. Additionally, another important point about the counseling is the possibility to consider clinical trial enrollment for patients who are willing to preserve their childbirth potential, but I think that this can be applied just in a very selected group of patients because also the collaboration with our oncofertility group will help us identify the most appropriate candidate. Concluding, definitive surgery remains the safe course whenever malignancy cannot be excluded. However, there are many cases in which the diagnosis is performed after myomectomy for apparent benign sarcoma.
Yeah. So now let's get into a little bit about treatment. And this question is from Matteo Lovero at Policlinico Universitario Agostino Gemelli in Rome. And he's asking, based on the current evidence, which classes of novel therapeutic agents have shown the most promising results in the treatment of uterine leiomyosarcoma, and which molecular or immunohistochemical targets should be assessed to guide personalized treatment?
In the recent years, basket trials, which allow pan-tumor target therapies, provide us a lot of preliminary data. Anti-angiogenetics, for instance, represent one of the first class introduced in managing uterine sarcoma or soft tissue sarcoma in general. Pazopanib and nintedanib that inhibit vascular endothelial growth factor or platelet-derived growth factor receptors showed activity in soft tissue sarcoma, and to date, pazopanib is one of the most used second line and beyond treatment modality in the advanced setting. Olaratumab initially appeared promising that it is a monoclonal antibody directed against vascular endothelial growth factor, but the recent phase 3 ANNUNCE trial failed to demonstrate an overall survival benefit when olaratumab is added to doxorubicin. Another interesting treatment approach is represented by immune checkpoint inhibitors. In the last year, immunotherapy has gained popularity among oncologists and also gynecological oncologists. Pembrolizumab and nivolumab shows durable response in a subset of uterine leiomyosarcoma patients, and also the NCCN guidelines recommended pembrolizumab for unresectable or metastatic uterine leiomyosarcoma characterized by high TMB. Another intriguing target agent is represented by anti-HER2 medication. HER2 amplification is rare in soft tissue sarcoma in general, but recently trastuzumab deruxtecan has granted FDA accelerated approval for HER2 expressing solid tumors. Data about uterine leiomyosarcoma are scant, but it may represent something promising. The last class of medications includes PARP inhibitors. olaparib, niraparib, rucaparib, showed potential activity, preclinical activity in patients with uterine leiomyosarcoma. And in particular, it is important to highlight that about 5 to 10% of all uterine leiomyosarcoma are harboring a BRCA2 mutation, and up to 20-25% of uterine leiomyosarcoma are presenting an homologous recombination deficiency. The Italian sarcoma group investigated the role of PARP inhibitors in soft tissue sarcoma, and the Thomas-2 trial failed to demonstrate the benefit of combining trabectedin with olaparib rather than trabectedin alone. However, I think that new combination potentially can be promising in these settings. Molecular profiling should therefore include TP53, LB1, BRCA status, estrogen receptors expression, and HRD. Those would be useful to guide the inclusion in some clinical trial, but also in the future to tailor the most appropriate treatment approach.
Yeah. As I was listening to you answer that question, it's amazing how far we've come in the last decade when, previously the answer to that question would have been just, well, it's chemotherapy. And now there's so many different potentially exciting options. So really thank you for giving us that broad spectrum of potential options for these patients. Now, Giorgio, this next question, it's an interesting question, comes from Carlota Sabini, near you in Ospedale San Raffaele, Milano. She's asking, could HIPEC play a role in the management of uterine leiomyosarcomas following accidental morcellation?
Biological assumption, my answer would be yes, because by a theoretical point of view, HIPEC is gaining popularity. We started with colorectal surgeons performing HIPEC for recurrent GI tumors, and right now HIPEC is under investigation in the setting of ovarian cancer. Cytoreductive surgery plus HIPEC provide a local control. However, I have to say that to date, HIPEC remains investigational in this context, and we cannot recommend these outside a clinical trial again.
Yeah.
But it will be promising potentially and interesting too.
Yeah. Another interesting question from Paula Mateo here at Houston Methodist, actually. She's asking, in the article, it is mentioned that there is no survival benefit associated with bilateral salpingo-oophorectomy. In patients with ER/PR positive tumors, would you still recommend preserving the ovaries?
For FIGO stage 1 disease, literature is concordant in saying that hysterectomy alone is the standard treatment modality for patients in premenopausal patients. In fact, no survival benefits from bilateral salpingo-oophorectomy was observed. Moreover, we have to take in account that ovarian metastases are rare, about less than 5% in most series. So ovarian preservation can be considered in premenopausal patients, even with estrogen receptor and progesterone receptor positive tumors. A multidisciplinary discussion, however, is recommended. After menopause, bilateral salpingo-oophorectomy remains standard, mainly for hormonal suppression rather than proven survival gain.
So another question from Tommy Meschini, and he's asking now, as reported and supported by the cited studies, adjuvant chemotherapy generally not recommended for patients with stage 1 disease. In your clinical practice, if a patient underwent morcellation or myomectomy, in addition to completing surgery, would you consider offering adjuvant therapy in stage 1, given the potential risk of intraoperative dissemination?
Again, Tommy made a challenging question. I think that there is no specific rule. Observation after surgery is the standard approach for stage 1 uterine leiomyosarcoma, since again adjuvant chemotherapy has not shown clear survival benefit in multiple randomized controlled study and in meta-analysis of those studies. If morcellation or incomplete surgery occurred, re-excision, surgery again, if possible, is recommended for removing all the macroscopic disease. Adjuvant therapy may be considered on a case-by-case basis because of the theoretical risk of dissemination, but today evidence is not sufficient to support the routine use of adjuvant chemotherapy after morcellation without the detection of gross disease.
So now, Giorgio, this question comes from Mathilde Del from Toulouse in France, and she's asking a question that is often asked by patients. Are there hereditary forms or genetic predispositions to uterine leiomyosarcoma? And if so, what surveillance strategies are recommended for women at risk?
The majority of cases are sporadic, then no genetic predisposition exists. But in some cases, some few cases are may be related to hereditary cancer syndromes. That includes hereditary leiomyomatosis and renal cell carcinoma due to alteration of the fumarate hydratase FH gene. And the second one is the leaf-forming syndromes related to TP53 mutation. For women with known genetic syndrome, or also for women with early onset of multiple leiomyoma, genetic counseling and close gynecological surveillance are advisable.
Now, this question comes to us from Zaniru Marin Martinez in the Instituto Nacional de Cancerología in Mexico. And he's asking, are these findings and recommendations that you're describing applicable to all leiomyosarcomas given the heterogeneity of these tumors?
You are right in asking this question. I think that uterine leiomyosarcoma are rare and heterogeneous. And the most available evidence comes from a retrospective series, small retrospective series, or soft tissue sarcoma extrapolated data. To enhance the generalization of our data, we developed a collaborative group that includes international opinion leaders and experts spanning in the US or Europe, Asia. And also we followed the recent ESGO-European GCIG guidelines. We emphasize in this paper that the global cooperation is the key, and data centralization is necessary to ensure that recommendation can be applicable across different countries and different healthcare systems.
So now this next question is back to Spain with HC Villagra, and she's interested in recurrent disease setting. She's asking, the treatment of recurrent disease, surgery is recommended when the disease is resectable. In which cases should we consider preoperative systemic therapy and or radiotherapy?
Recurrent disease is not uncommon in patients with uterine leiomyosarcoma. Recurrent disease often manifests with abdominal pelvic relapse or also like isolated lung metastasis. Surgery is recommended when recurrence is resectable, including case of isolated metastasectomy or in case of oligometastatic disease when feasible. Preoperative systemic treatment in general, doxorubicin-based chemotherapy, may be used for downstage the tumor, but also for test chemosensitivity. Radiotherapy, external beam with or without brachytherapy, can also be applied post-surgery in case to achieve local control or in case of palliative treatment, in case of unresectable pelvic recurrence or in patients who are not able to tolerate the risk of morbidity after surgery. Systemic treatment option for unresectable disease includes doxorubicin with or without trabectedin, followed by trabectedin maintenance. It is not available in Italy, but there are other countries in which this regime is already available. Gemcitabine plus docetaxel, and in second line we have again pazopanib, trabectedin, or other monochemotherapy. Clinical trial participation is strongly recommended, and also we have to take in account that multidisciplinary approach and individualization is very important, because we have to consider the disease distribution, then the location of the metastatic site, the disease-free survival, prior treatment, performance status, but also the patient's willingness and what we have to expect for the treatment.
Excellent. So, Giorgio, this topic seems to come up regardless of which GYN cancer we're discussing these days. This question comes from Mo Byrne, who is at Memorial Sloan Kettering Cancer Center in New York City. And she's asking, there's some lower level data to suggest a potential role for ctDNA, circulating tumor DNA, in predicting disease burden, treatment response, and disease progression, overall survival in leiomyosarcoma. Going forward, what role do you think ctDNA may play in the diagnosis or management decisions in patients with leiomyosarcoma? And given the heterogeneity of the disease, how would you propose we further study ctDNA as a potential actionable biomarker in this disease?
I think that ctDNA is one of the most intriguing method and emerging method to observe, but also to provide early diagnosis in several gynecological cancer. I attended with great interest the recent podcast you had with Brad Monk about the ctDNA for patients included in the CALA study, and I suggest to hear about this podcast. I think that to date there is a low evidence suggesting that ctDNA may correlate with tumor burden, treatment response, progression, survival, and prognostication in patients with uterine leiomyosarcoma. Hence, the level of evidence remains preliminary in this setting. Further research must include prospective longitudinal and multi-center studies that have to integrate ctDNA with imaging, radiological, and clinical endpoints to stabilize if ctDNA can be a biomarker for early diagnosis or for surveillance of patients receiving a treatment.
Yeah. This question is a topic that we haven't discussed so far. This comes from Paula Mateo. She's asking about screening. The article states that understanding the epidemiology of the tumor is crucial for identifying risk factors and tailoring screening. How would you envision a potential screening approach for these tumors?
Unfortunately, there are no screening tools for uterine sarcomas due to their rarity and due to the lack of specific biomarkers. However, understanding tumor epidemiology is essential to identify at-risk population, such as women who are older or in postmenopause, Black ethnicity, exposed to prior pelvic radiation or long-term exposure to tamoxifen, because for such high-risk individual, the only feasible measure is to enhance clinical surveillance and implementing imaging for assessing changes in the uterine masses is present, and also for assessing the presence of atypical or rapidly enlarging lesions.
So, Giorgio, now we have just a couple of questions, and this question pertains to global practices. Comes from Joni Naveau, as I mentioned, in beautiful St. John's, Newfoundland, beautiful corner of our world. And she's asking, your review highlights that despite the 2024 ESGO, Eurocan, GCIG guidelines, real-world practice for uterine leiomyosarcoma still varies widely between countries. From your perspective, what are the biggest barriers to harmonizing care globally? How can we bridge this gap between consensus recommendations and actual clinical practice?
Yes, it is an interesting topic. Our paper highlights that despite the HESGO guidelines, but also despite the efforts provided by HESGO and the International Society of Gynecological Cancer, there is a substantial variation in the real-world management of uterine sarcoma across countries. I think that there are four main barriers that includes the limited awareness of best practice, especially in regions where the incidence of sarcoma is low. There is a restricted access to specialized pathology review and also molecular testing. And then there is also a variability in healthcare system infrastructure. And finally, and potentially most importantly, there is a paucity of prospective clinical trial and a paucity of data regarding soft tissue sarcoma, but in particular, paucity of data about uterine leiomyosarcoma. To bridge these gaps, our study group advocated for an international collaboration, centralization of care in referral center, and data sharing networks that can harmonize treatment and research globally.
So Giorgio, as a tradition now, we have in the podcast as the last question. This is a question that was formulated purely from AI and AI's interpretation of your review. So the question is, despite advances in molecular profiling that reveal substantial biological heterogeneity, your review continues to recommend total abdominal hysterectomy and bilateral salpingo oophorectomy as a uniform standard. Should surgical aggressiveness moving forward be guided instead by molecular subtype, hormonal receptor status, or radiogenomic risk signatures similar to personalized paradigms emerging in other gynecologic cancers?
Although molecular profiling has revealed major heterogeneity, mutation in TP53, LB1, ATRX, but also BRCA genes, HRD, and a variable expression of estrogen receptor and progesterone receptor. Current evidence does not justify to tailor surgical extent, but also adjuvant treatment to those molecular or hormonal factors. Thus, today, total hysterectomy with or without bilateral salpingo-oophorectomy remains the standard of care for all resectable disease. Obviously, I agree with the AI that further research may clarify whether molecular subtypes, hormonal receptor status, or also radiogenomic signatures could guide surgical aggressiveness. But to me, the most important point is the adjuvant treatment. But to date, obviously, this is still investigational.
Excellent. So, Giorgio, once again, it's always a pleasure, obviously, speaking with you. Learned so much from you. You really did a tremendous amount of work for this project, and I commend you for it. Thank you for providing us with this tool for this very rare disease, but a disease that we often see in our clinical practice. And this, I think, will be a great reference manuscript for many of us, and certainly for our trainees as well. So I want to thank you for all the time and effort that you put into that. Also, again, thank you for all the many contributions that you have already made throughout the course of your academic career. So really a pleasure again talking with you and speaking with you and seeing you. So thank you.
Thank you, Pedro. Thank you so much for your big efforts in this project and also for the podcast and the international journal. Thank you so much. It's an honor for me.